Hello and welcome. Today we're diving into the world of the urinary system to understand a condition called nephrogenic diabetes insipidus, or NDI. This is a rare but important disorder that affects the kidney's ability to concentrate urine, leading to a variety of symptoms and potential complications. Let's explore what causes it, how it affects the body, and what can be done to manage it. So, what causes nephrogenic diabetes insipidus? Unlike diabetes mellitus, which involves problems with insulin and blood sugar, NDI stems from issues within the kidneys themselves. It can be congenital, meaning it's present at birth due to genetic mutations affecting the kidney's water channels, called aquaporin 2 or the vasopressin V2 receptor. Alternatively, it can be acquired, developing later in life. Acquired NDI is often triggered by certain medications like lithium, used for bipolar disorder. Other possible causes include kidney diseases, electrolyte imbalances like low potassium or high calcium, and even certain systemic illnesses like sickle cell anemia. To understand NDI, we need to understand how the kidneys normally work. The kidneys filter blood and produce urine. A hormone called vasopressin, also known as antidiuretic hormone or ADH, signals the kidneys to reabsorb water back into the bloodstream. In NDI, the kidneys don't respond properly to vasopressin. This is because of problems with aquaporin 2 or the V2 receptor. Even though vasopressin is present, the kidneys are unable to concentrate the urine. This leads to excessive water loss through urine, dehydration, and the other symptoms we'll discuss. Nephrogenic diabetes insipidus is a relatively rare condition. Congenital forms are quite uncommon, often linked to specific genetic mutations within families. Acquired NDI, while more frequent than the congenital form, is still not widespread. The prevalence of acquired NDI is often tied to factors such as lithium use and the presence of underlying kidney diseases within specific populations. Precise global statistics are difficult to obtain due to the variability in diagnostic criteria and the presence of underlying causes. The most prominent signs and symptoms of NDI are excessive thirst, also known as polydipsia, and frequent urination, especially at night, termed nocturia. This excessive urination, called polyuria, can be quite significant, with individuals potentially producing several liters of urine per day. Due to the constant water loss, individuals with NDI are prone to dehydration, which can lead to symptoms like weakness, fatigue, constipation, and in severe cases confusion, seizures, and even coma. Infants and young children with NDI may also present with failure to thrive, irritability, unexplained fevers. Diagnosing NDI involves a combination of medical history, physical examination, and specific tests. A doctor will assess the patient's fluid intake and urine output. Urine tests will measure the volume and concentration of urine, looking for low urine osmolality, which indicates dilute urine. Blood tests will evaluate electrolyte levels and kidney function. A water deprivation test might be performed under close medical supervision to see how the body responds to fluid restriction. A desmopressin challenge, where a synthetic form of vasopressin is administered, can help differentiate NDI from other forms of diabetes insipidus. In NDI, the kidneys will still not concentrate the urine after desmopressin administration, while in central diabetes insipidus, the urine will concentrate. While nephrogenic diabetes insipidus isn't strictly classified into distinct types beyond congenital versus acquired, the underlying cause can be further categorized. For example, within congenital NDI, specific mutations in the aquaporin 2 gene or the V2 receptor gene can be identified. Acquired NDI can be classified based on the causative agent, such as lithium-induced NDI or NDI secondary to chronic kidney disease. The primary goals of treatment are to manage fluid balance, prevent dehydration, and address any underlying causes. Treatment usually involves drinking plenty of water to compensate for the fluid loss. Dietary modifications, such as reducing salt and protein intake, can help decrease the kidney's workload. Certain medications, such as thiazide diuretics as often combined with amiloride, can paradoxically reduce urine volume by promoting sodium and water reabsorption in a different part of the kidney. Addressing any underlying electrolyte imbalances or kidney diseases is also crucial. In lithium-induced NDI, discontinuing or reducing the lithium dosage, if possible, may improve kidney function. While not always preventable, especially in congenital cases, acquired NDI can sometimes be prevented by carefully monitoring kidney function and electrolyte levels in individuals taking medications like lithium. Regular check-ups with a doctor are essential for early detection and management of any underlying conditions that could contribute to NDI. Awareness of the symptoms of NDI and prompt medical attention can help prevent dehydration and other complications. The prognosis for individuals with NDI varies depending on the underlying cause and the effectiveness of treatment. With proper management, most individuals can lead relatively normal lives, although careful monitoring and adherence to treatment plans are crucial. Congenital NDI can be more challenging to manage, especially in infants and young children, and can sometimes impact growth and development. Recent research is focused on developing more targeted therapies for both congenital and acquired NDI, including gene therapy approaches for congenital forms and novel medications to improve kidney function in acquired cases. Researchers are also investigating the role of specific genetic mutations in congenital NDI to improve genetic counseling and potential future treatments.